Good afternoon and welcome to Coordinating IT Training to Improve Usability and Reduce Burnout, a health system CIO production. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You can send in your questions or comments at any time in the Q&A box, and we will take those later in the program. This is how we're going to start. We're going to go about 35 minutes with our main panel discussion featuring Gretchen, Britt, Liberty Market VP Information and Technology, CIO, the University of Kansas Health System, Dr. Clara VP and CMIO at Seattle Children's, and Dr. Dirk Stanley, CMIO with UConn Health, and then we will have our Q&A. So let's jump right in. Gretchen, can you give us an overview of your organization and your role? I apologize if I botched your title. Did I get that right there?
No, it's a lot. It's kind of a
Yeah.
mouthful. I hear you. Gretchen Britt, I am the Liberty Market CIO. I'm with the University of Kansas Health System, which is a large academic medical center in Kansas City, Kansas. We have many actually different locations, 9 hospitals now, with over 150 locations. And Liberty Hospital, I'm proud to say, is our newest hospital, which is really exciting. So we're a 204-bed community hospital and we have 15 clinics, and I am responsible for the information and technology at the Liberty Market location. It's really exciting. So happy to be here, and thanks for having me.
All right, Gretchen, thank you. Uh, Dr. Lynn.
Hello. Thank you for having me here. I'm Clara. I am a primary care physician, internal medicine and pediatrics trained. Now I'm just a general pediatrician. My regular day job is our CMIO at Seattle Children's and also our VP over digital health and training. So I oversee our training team as well as our digital health and our informatics team. Seattle Children's is a tertiary pediatric referral center covering the states of Washington, Alaska, Montana, Idaho, and some of Oregon. And we are actively looking at ways how we can continue to engage our clinicians, our users, and also our families and patients in this digital new world.
Excellent. Thank you very much. Dr. Stanley?
Hi, and thank you for inviting me. I'm Dirk Stanley. I'm a physician. I'm a hospitalist by training and also board certified in clinical informatics. I'm the CMIO at UConn Health. We're based in Farmington, Connecticut, large academic medical center, multi-specialty. We're still primarily one hospital. We're not part of a network, but we're recently, if you look in the news, there's, discussion about, other opportunities to partner with other hospitals in the region. And I help oversee all of our development, our clinical informatics, our training, and other things. And I write about it at night on a blog, and that's who I am. So thank you.
Oh, very, very welcome. All right, let's jump right in. Dirk, we're going to start with you. Describe the main challenges around clinical application training. Why is this such a difficult problem to master?
So, I have a lot of thoughts about the matter, but if I had to condense my thoughts, it's people don't think about training very much. They don't, everyone is very focused on the technology and they're focused on implementing the technology, but they don't, people don't really put a lot of thought into what does it take to implement the technology and how is that going to change people, the actual day-to-day practices for the doctors and nurses and pharmacists and case managers and social workers and dietitians and all those other people who help take care of the patients. How is it going to impact them? What will it do to the way they practice, routinely go about their day-to-day activities? And maybe even more importantly is why? Why do we need to change? Because if you don't explain to people why they need to change, then healthcare starts to feel like, overwhelming. It starts to feel like, I'm just being told we have to do it. Most changes are actually to improve patient care. But if you can't connect the change with the heart of the people that you're changing, if they don't know what the relationship is between, patient care, it's very difficult to adopt things. So I always make sure that of all the deliverables that, all the blueprints that we develop, our order sets, our flow sheets, our, alerts, that training is is a deliverable just like everything else, and it requires the same sort of thought, design, analysis, and it really needs to speak to the people who are going to be implementing the technology. So there you go.
All right. Well, we'll dig we'll dig into that very much. Clara, your thoughts?
I, by the way, big fan of Dr. Stanley's. I'm taking notes as he's speaking about this particular topic. Training for us, I think we have seen, particularly for providers and clinicians in general, the most effective and the highest yield and when it comes to achieving user engagement and user satisfaction is at the elbow training and that type of really live engagement. But that takes a lot of resources on the system side. And so to Dr. Stanley's point, when people don't think about training, people don't prioritize training. And when people don't prioritize training, the system doesn't prioritize training. And so if we're not investing in the time and the resources that it takes both for the trainers and the users, then it's a very tough problem for us to overcome, to implement something we know that works. We know that in data, it shows training is closely associated with improved satisfaction, reduced burnout, mastery of the tools. But I think my hardest part is convincing the people that write the checks that this is something that we do need to prioritize.
All right, we'll dig in there. And Gretchen, as I said about Dirk before, that this is a topic near and dear to his heart. I've seen you write about this topic as well, so this is something important to you.
I have, yes, and it is. So I want to say yes and yes to both what Dirk and Clara said. I am a nurse by background, so I am also a clinician, and I think it is so vital that we meet our people where they're at and do that at elbow training, which again, as Dr. Lynn stated, we are limited by funding, we're limited by culture, we're limited by buy-in. We want our clinicians out, producing those RVUs and seeing patients, right? Because that's what they're there to do. But I think we have got to set them up for success, which means being intentional with that training. It means finding the right way to meet them where they're at, whether it's a push pull, there's all different ways. I myself am a see one, do one, teach one kind of girl. So I want to get in and get my hands dirty and I want to touch it and I want to ask questions where others may want to go out and watch a video or learn. So I think we have challenges because we try to maybe fit all the people into one way of doing it, and we're not adapting that training to those users, to their specialty, to their needs, and meeting them where they're at.
All right, so let's go into a couple of things here. First, let's talk about that the where they're at the elbow. We've heard that a couple of times. Um, and my wife's a nurse practitioner, and from what I understand of clinicians, which is limited, they're very, 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 very busy, and they're always working. And sometimes she'll say she didn't get a break here or there. So being where they are and where they're working and at the elbow makes a lot of sense because a lot of time there isn't, I'm guessing, there isn't the bandwidth to, hey, let's have an hour meeting in this room and we're going to pull you out of your area of work because a lot of times you're really making it rough on the other people who are left without that resource because people are stretched thin. So the concept of pulling people out of their workflow is probably a very challenging one. You'd probably get a lot of pushback from managers and everyone else if you were constantly trying to pull people out. Does that make sense? Dirk, let's start with you.
I think training, I mean, what you're touching on is uh, like all the different components of training, right? There's the elbow to elbow, there's pulling the people out to help with the elbow and elbow support, getting them trained. There's having champions in, not just physician champions, but nursing champions and pharmacy champions. But training is also, for some projects, like for complicated projects, sometimes you need class, like almost, electronic. We do this with some sort of electronic training, like, click here to open the link and watch this video or this presentation. Training is also the clinical decision support strategy that you use. It's, how do you label the tools inside your electronic medical record often is like important for training purposes. So it's like, there's so many different aspects of doing training well. and you want to cover all those aspects. And for certain projects, elbow to elbow support is definitely going to, you're going to lean more heavily on that. For other projects, you're going to need, elbow to elbow support and videos for like, so it kind of depends on the size and the complexity of the project. But I don't know that you can, every project has its own unique needs. And once after you've done your gap analysis and you really understand the current state and the future state, then you can really plan out all the components of training that you would need. So I'm not sure there's one size fits all, but I recommend, I'm curious what our other colleagues feel about that.
Clara, thoughts?
Yeah, I agree. Every project and every change, the magnitude of change really is different, and the retraining required and the change management required effort is very different from project to project. I will say, though, we also try to have sort of a baseline presence in the hospital. And so we do have a team of our clinician trainers that are roaming around the hospital just at all times. We also have them set up pop-up stops different clinics and specialties every once in a while so that the clinicians can go to them at their convenience. We have a direct hotline for that team that roams around the hospital to the clinicians that can then a lot of them actually have we have physicians that save them as their speed dial now, and so that hotline is always answered by a trainer. And then we also know being at the elbow or at the point of care doesn't mean that you have to be there in person. And so we're trying also very hard to make sure that training and the teaching and the education pearls are inside the applications at the time where it's needed. So, Epic used to have those how-to videos. We didn't get a lot of uptake on that. No one really watches it when you're in the middle of like trying to see a patient, but we try to put here and there little things that will give people pearls, and also what we're calling internally the TikTok type teaching, where it's just very short learning wherever it matters. And so that's one way that we've been approaching it. But there is still a larger problem of if it's a big project and a big change, how do we get people to make time to come to it?
Gretchen?
I love the TikTok training. I think that's great. I think it's a fantastic way to do it, the little short videos. I think for us on the Liberty market, I'm going to speak to that first. We have our physician support coordinators, right? Those are the ones that do the at elbow training for all new providers based on their specialty. So it's training that is special for them on what their workflow is going to be. An example would be our ER physician. We're going to meet with them. We're going to show them how they will work. And then our physician support coordinator will sit with them for the first 4 hours of their shift and make sure that they have the right tools that they need if they have questions. Post that training, we have our bat phone. We also have that direct line that goes straight to those folks to say, hey, I need help. I can't remember. What they also do is if they're having a problem or they're stuck, that's one way where they can call and say, I'm having this issue. They can go and either remote in or they can go at elbow, get the information that they need so they can put in a ticket and help be that bridge, that bridge from the technical folks to the clinicians so they can focus on patient care. So that's been something that's been successful for us on the Liberty market. And now, as you can imagine, right, going through this new partnership with the University of Kansas Health System, we are going to be on learning overload here. So I've been really impressed with the Change Champions model that they've got to help messaging, to get that message out. There's somebody located in each department to help us with that messaging, followed by different training methods, whether it's videos, whether it's tip sheets, whether it's webinars, whether it's in classroom training. Again, it's going to be dependent on the size and scope of the project. But I love the messaging and making sure that we're communicating the why. I think it was Dr. Stanley, you spoke to that earlier. This is why we're changing. This is what we're doing, and this is how we're going to do it. And this is how we're going to be here to support you. So I'm getting the new academic model and the new larger health system way, but I love our small, community hospital team that we've got here and how we've shown success with our physicians.
Okay, so it sounds like there's a lot of everybody's doing really cool stuff, and we have a lot of great ideas. We did touch on the idea, and that I want to go into more in a minute about having trouble getting the resources that we need to do all these things. So it sounds like we're doing a lot of great things. We have a lot of great ideas. So I would say, well, it sounds wonderful. What's the problem? Is the problem that we don't have it budgeted to do as much of this stuff as we want? Or is the problem that we still, although we have all these ideas, we're still not having the absolute outcome that we want? So maybe we're getting there, but we're still not where we want to be in terms of training. So let's take those two issues. Gretchen, if you want to go first, how much of an issue is not getting the resources dedicated to training that we need? And so we kind of run out of funding on some of this stuff versus we have all these ideas and we're still not quite there. We're still not getting the outcome we want.
Yeah, I think part of it is definitely resources, right? Funding. Who's going to be the right person to do that training? I think we all learn best from our peers. So nurses teaching nurses and physicians teaching nursing. Ideally, that would be great. I don't know if that's realistic and we can pull all those folks out to do that. I think with the funding issues and not being able to have enough resources to be able to meet the needs of everybody at elbow, I think that's a challenge. I think maybe we don't utilize some of the standard, maybe built-in tool tips or education that's there as often as we should, and something that we should be digging into deeper to see where can we use those already built education materials. But we have to be careful, right? Because once we've customized something, we've now made that tool useless because it's not something that's going to be applicable to the way they do their work if we've gone and customized it. So I think it's a balance, and I think it's been a challenge for us having the right ones. I've slowly built up the physician support team, but I had to justify it. You know, how are we improving their workflow? How have we improved their satisfaction? How have we decreased their workload and their burnout by setting them up for success at the beginning? And I think it's continuous messaging of that, but it takes time, right? We have to have metrics, we have to show improvement, we have to show that we have done the job to be able to justify those positions. And I think with our super users, if we're not going to maybe compensate them or make them have this as a true role, I think that can really limit their capabilities and their opportunities to help those where we could tap into those subject matter experts that are right there at the point of care, at the bedside, because I don't think we allow them the time to, one, stay up on training, and two, to really focus and be able to put the effort into supporting their end users and their areas. So I think budget's a big part of it, and I think culture is a big part of it as well.
Excellent. Dirk?
Yeah, I agree with Gretchen totally. When the budget and the culture are really two things that that become important in this discussion. When I look at the last 50 years of healthcare and the introduction of electronic medical records, it has generated so much change. And a lot of the change is there's the sort of change on the micro level, and then there's the change on the macro level. Even just sort of the understanding of education and training is, there's sort of we're often in healthcare, we're often faced with the ghosts of healthcare past. And some of that changes, like, well, nurses educate nurses, doctors educate doctors, pharmacists educate pharmacists. And as a result, and I've worked in a number of different hospitals, and I'm always fascinated to see the training resources for nursing versus the training resources for physicians. And I always ask, like, why do we not have more training resources for physicians? And the most common answer that I've heard from people, not, just generally, is, well, doctors went to med school. They, what more training do they need? And I'm trying to often explain the difference between medical training and actually how to use the new heparin order set or something that you're building. And so, like, even just creating this understanding of that, like, training is a continuous lifelong thing. Like, you're going to need training routinely for the rest of your life. And it's not just your continuing medical education. There's real training that you're going to need to use and navigate the electronic medical record successfully. So, we're kind of seeing the ghosts of the past, the vision of the future, and all of us here are like navigating those two worlds. Clara, do you have thoughts about that? Or
No, I think that's really, really spot on what both you and Gretchen said. To me, I think there's a third layer, I guess, or maybe a separate consideration to budget for providers particularly, and that is every hour they're spending in training is every hour they're not seeing patients. And so the resources on the learner side was hard for us to justify protecting time for clinicians or for providers, billing providers particularly, to not be able to see patients. And so imagine like an hour downtime across all providers at the same time, and everyone's not seeing patients. That's a pretty big loss to the hospital. And we can't do that for every application, every project, that we're trying to roll out. And so that I think, and even when we do know that for particular projects or particular applications, that is absolutely necessary. And providers want to come and do the 1 hour, and we have trainers want to come and do all the training and put together all the material. It's hard to convince the system that protecting and removing these providers for an hour is going to be worth the return.
Very interesting, right? So there's a lot of reasons that this is challenging. I'd like to, Gretchen, I'd like you to go first, and I'd like to explore the topic. It sounds like you built out an informatics capability or team or training team, and it sounds like it took time. And I would like you to talk more about that for the benefit of others who are either trying to start something up or to build out the resources they have. You mentioned the idea of justification. It sounded like there'd be a lot of metrics involved here that you would want to leverage both in your initial ask for resources and then continued justification of any resources you'd been given, along with the idea of trying to expand any resources you'd been given. You want to show, here's where we were, and based on the resources we have in training, here are how the outcomes have improved and physician satisfaction. So I'd like you to talk more about that again for the benefit of others that are trying to get these resources justified or expanded.
Well, fun fact, I started as the very first physician support coordinator. So when I came over from the bedside, I was fortunate to interview for the role. And I remember the manager at the time talking to me about it. And I was really, do I just want to do training? Do I want to do, is this going to be enough? What do I want to do? And she said, make this role what you want. So we took this role, and we had some satisfaction issues with our providers here, right? They didn't feel like they were getting what they needed. They didn't feel like they had a successful foundation for them to be able to care for their patients. So that was the driving factor. I don't think we had data, we had loud voices at Liberty. So with that, I was able to come in and we were able to prove that our physician satisfaction was up just by hearing their feedback, honestly. We were able to drive projects through our physician information and technology committee to show that we could reduce clicks, that we could, solve their issues, that we were partnering with them. And I don't know that we produced a lot of data, which is probably not what we want to hear, because usually data is what should drive our decisions. But we were able to take the physicians' voices and truly becoming a partner with them and take that to our leadership team. So that was on the acute side. So when I came over to take the role that I sit in currently, I asked for another one for the ambulatory side, where we were having some of those same provider burnout, provider issues. How can we help bridge that gap over there? So building that team. Then it became, okay, we're getting more providers that are coming to Liberty, and we do the nurse practitioners as well as the physicians in this training. So it became the numbers and the sheer magnitude of them trying to keep up, because they don't just do the training, they also do that at elbow support. They put in their tickets, they help them through issues, they do refresh training, the new user training. They go to many different meetings to hear what's new and coming and how they can help. So I think for us, it was just that buy-in and that word of mouth from our physicians who said, wow, this is really helping us. And we were fortunate to then get those positions justified, or even take another position and say, you know what, this isn't the best use of it. We need to slide it over here now, because this is where we need to focus so that we can help our end users.
Yeah, and I'm going to go around the horn, but I have heard this idea. You mentioned not leveraging data so much as opposed to loud voices, and I've heard that in some recent discussions I've had with IT executives in terms of getting buy-in among CFOs and other financial types, getting the dollars they need. This idea of bringing influential voices to them can be extremely effective. So that's something that should be in everyone's arsenal, right? Because some of this stuff has soft ROI, or there's not as much data there. If you bring the influential folks who want something that you are trying to move forward, you bring those two people influential, have to have a conversation. that can be effective. So at least from what I've heard. Gretchen, anything else you want to
Yeah,
add there?
I think you hit it there on the head. I think having the right people to help you tell the story to justify the need when you maybe don't have the data to back it up can help prove that soft ROI. And that was something that was definitely um, uh, important for us to bring these new positions to Liberty and to help our physicians. And we're not perfect. We have a long way to go, right? And we are learning so much new, and there's going to be a lot of new things coming our way and new ways that we do training. But I do think that this program that we've built here has been successful for our physicians. And I thank them for their support and their partnership. They have been key to helping us move the needle, whether we're working on an issue with technology, with a new workflow, with new education. I think they have been instrumental that it has to be a partnership between informatics and the training has to be a partnership between the clinicians and has to be a partnership through IT and operations, right? It's a partnership all the way around.
All right, Clara, let's go to you. Let's stick with the idea of this is super important. We know this is super important. There are certain perceptions there. Bringing some of this stuff together. There's a perception that, which Dirk mentioned about, well, you're a doctor. Why do you need training? You're smart enough to figure this out. And there's the impression of consumer devices, which is like, I don't need training for my iPhone. Why do you need training for this? So there could be a perception that I don't understand why you need training. And then there's all these issues of, well, it costs money to do training. It pulls them off the floor. They're not billing. So for like a billion reasons, let's not do this. But there's the increase in burnout. There's the frustration of using the tool. Right? So long story short, what are you seeing as effective in justifying resources for this? Or, and I know you said you're still working to move down this road. There's still work to be done here, but what have you found so far can be effective in convincing the people that write the checks to agree to invest more in this area?
Uh, Yes, I'll definitely get to that. But I wanted to add one more thing to the
Yeah.
seesaw that you mentioned, so the balance of I also see what I also see is when an application doesn't work or when we're planning out a project, everyone blames training, right? That everyone goes, well, we just need more training, or that's a training problem, or that's a user training issue. And so we know that training is pivotal, but no one wants to to really focus on it or prioritize it. So I think the way that what I have noticed in the last 9 months since training started to report into me, where I also oversee the informatics team, to Gretchen's point, there's been more collaboration between the two groups. And that has been really, really helpful for us to sort of informatics to help design the training curriculum and sort of figure out how to penetrate the very difficult to penetrate provider population, and how to speak a provider's language and get into their hearts, and also training to really inform what a learning design looks like for the informaticists, because sometimes we just know that we'll show up on the floor and start talking, right? And but our training team has the expertise in designing the curriculum that is suitable for a busy clinician or for adult style learning. And so I think that collaboration between the two has been really helpful. There's also been situations where training is required. So, like ambient, for example, in Washington State, it's required by state law that we obtain consent for all the parties being recorded for the ambient AI tool that we're doing. And that piece of information right there was crucial for us to get to our clinicians that are going to be using the ambient technology. It's not just about turning it on your phone. We have to make sure that you know that you need to consent and how you consent. And so there's also that sort of required training piece. And so how we've been doing it is really finding, if it's in a situation where we cannot convince people to let us protect an hour of time for providers, we show up to their 1 hour time that they're doing something else otherwise. And so the trainers and the informaticists will go to their faculty meeting and block out that hour for our talk and for our content. We'll go to their lunch rooms and we'll say, this is your lunch hour for clinic. Everybody will bring in lunch and everybody show up. We'll bring you cookies. And this is what we're going to be talking about for an hour. And we've also started to really try to infiltrate training into the different departments and divisions, and basically train up a couple of people and say, you're going to be our our eyes and ears and our inside source in this division, but you're also going to be, we're going to teach you, and we're going to, you'll have all the IT resources, and you'll have an insider line to the IT teams as your super user in your group. Super user is not the right word, but super trainer, I guess, in your group. And you'll be sort of helping us communicate some of these tidbits and tips and tricks to your group. But at the same time, we're providing you not so much FTE because we don't have the money for that, but we'll provide you the resource and the support that you will need to do this role right.
That's excellent. A couple of quick follow-ups, and then we'll get to you, Dirk. You mentioned bringing two groups together. Tell me, just to clarify, which groups are we bringing together?
Yeah, my physician and provider informatics group. So they're all clinicians that are informaticists, and then the trainers, the principal and credential trainers.
And the trainers, this group of employees, where does that live in the org chart?
So now they live in IT. So they report to me, and I report to our CIO.
But you said that's new, that things have come together under you. I'd like you to talk a little bit more about how they were structured previously, and apparently it's an improvement now that things are under you. So this is very important for people to understand. Sometimes where things lie in the org chart and the governance, so to speak, matters a lot, and making some tweaks there can have a big effect. So could you go into that a little bit?
Yeah, so previously they they were sort of their own little island and reported directly to our CIO. And so our CIO, they were still within IT, but they reported directly to the CIO. And I think that, to me, that scope is a little bit too broad. And so it was hard for them to focus and get the support that they needed to do their work. And so now, once they started to report under me, we were able to sort of focus on sort of our metrics for the year, our priority projects for the year, in alignment with the clinical opportunity, the priorities for the hospital.
That's great. Dirk, jump in. I mean, there's been a lot going on here. What are your thoughts?
Yeah, I mean, if I could underline and highlight everything that Gretchen and Clara were just talking about, the only thing I can do is summarize, like, and I think really the take-home points that I'm hearing and I agree with is training is not a tool, it's a toolbox, right? It's a bunch of tools, and you have to think about, for everything that you do, which tools you're going to need for, implementing. And the other thing is, from a budgetary standpoint, healthcare sometimes really suffers from, I'll call it budgetary myopia, right? We're often so focused on the seed that we completely forget about the soil. And so, like, part of when you don't have good data to show the return on investment for training, that's where storytelling, and I love what Gretchen said about, like, sometimes you actually have to help executives understand that, like, and you can do this through careful storytelling. You can also do this through careful project analysis, but you show, like, the training is absolutely essential for delivery of this project. Like, you can't get to the finish line without including the training and education. And especially for big projects, there's so many different tools you're going to need to implement. So, like, just helping them sort of understand what are the tools in the training toolbox, that you can't just budget for the seed, you have to budget for the soil. These are some of the things that I think can start to win people over. But obviously, as I think the three of us are all, in agreement, there's still so much work that needs to be done.
All right, very good. Clara, I want to go back to you and go into something a little more and then around the horn with this idea. I really got a kick out of what you were saying about sort of a more aggressive approach to getting training done and getting in front of people. Meaning, if you're not going to give us an hour, if you're not going to allow them to come to us, so to speak, we're coming to you. We're going to find you. We're going to find your schedule. We're going to know where you are. We're going to know the different things that you're doing that we can infiltrate. You used the word infiltrate. It's an aggressive, in a very positive way, it's an aggressive approach. It's I love it. It's much better than the passive, oh well, we tried, I guess that's that. It's no, this has to get done and we're going to get it done. So it's great. Can you tell me more about that approach? Was that a shift from a previous mindset of the organization or the informatics department?
No, it is actually a very explicit strategy of our training team and our training director. All of our trainers are, my boss likes to say, extroverts by nature. and they love to be around people. They love to help people. It really, that's why kind of they're here. It's a very mission driven group. And so they make every attempt to be where you need them. And so, like I said, it's by making their phone lines available, their hotlines available to everybody. I mean, we went as far as deciding whether we should print it on a cookie and then hand out those cookies in the hospital. Right now it's just magnets and cards and notebooks and things like that. And then forcing providers putting it in their speed dial. That's one approach, but it's really this sort of engagement that they are so proactive and so good at, that we have seen. I mean, not to brag, but in 2021, well, I am bragging, from 2021 to 2024, our class score for training has just increased and improved significantly, not just in training, but very, very noticeably in training. And that has then we've seen translation into provider and nursing EHR satisfaction score, a huge improvement over the 3 years that between our last two surveys. And so I really think that sort of that the team wanting to engage and not feeling shy about just showing up and then saying, hey, I'm going to have a pop-up booth in front of your clinic today, whether you like it or not, is how we're doing it here.
I love it. I love it. Gretchen, what are your thoughts?
Infiltration, I love that. I'm gonna share a little infiltration story of my own. So back when we were rolling out EPCS, do you guys remember the Bitmojis? Everybody has a Bitmoji, your little
Yes.
cartoon character of yourself. We were really struggling to get provider buy-in for our it was actually the e-submit, so sending electronic prescriptions. So I made 4x6 little Bitmojis of myself where I'm creepy and looking through the blinds at them. And on it, and I taped one of these to the back of every single computer that they used. And on it, it said, hey, are you going to e-submit that? Question mark, with my phone number. So I left them my digits, and I would have phone calls from these physicians calling me saying, okay, you've been staring at me for a week. It's creeping me out. I'm ready to do this. And that's how we turned the tide. So sometimes using unconventional ways to infiltrate them is what we need to do. We also use that tactic with the inbox. And they started looking for the Bitmojis, knowing that something new was coming with that creepy little cartoon character.
That's fantastic. Dirk?
I agree with the infiltration strategy. So here's the anecdote I have from early in my career. I stumbled upon, and this is kind of a crazy story, but it's true. I was trying to figure out people to help infiltrate, right? I'm like, we need people embedded in different areas. And so I failed first by, I put up a sign. I was working in a small community hospital, and I put up a sign in the physician lounge, which for small hospitals, this is still a place where people might gather. And I said, come to the clinical informatics meeting, I want to talk about the electronic medical record. And I basically had no turnout, like maybe 2 doctors showed up and nobody was really interested. And then, I went home and I was sort of licking my wounds and kind of thinking like, wow, that, obviously I didn't get their attention. Like I didn't connect. So I was rocking my 1-year-old, now he's 17. I was rocking him, to sleep. And I happened to be watching Star Wars. And I thought like, what we kind of need Jedi. We need like somebody, and my apologies to Disney and George Lucas if you're in the audience, but I was thinking like we kind of need clinical Jedi. So I changed the sign and I said, instead of come to the clinical informatics meeting, I said, come to the clinical Jedi meeting, learn how to shape your workflows. And I had like 30 doctors show up to
Oh
the
my
meeting. They were
God.
all like, and I thought like, I think I stumbled upon something like what people are looking for is they want to know how to drive the car. They want the keys. So you have to sort of really appeal to the heart inside every nurse, every doctor, every pharmacist. And I always think as sort of my guiding principle, everyone I work with, I try to imagine at one point they wrote an essay about why they went to nursing school, why they went to medical school, why they went to pharmacy school. And if you can connect with that essay, whatever they wrote, it's very like you can really like bring them along and finding those people. And so bravo to Clara and Gretchen for finding those people and bringing them along and adding them to your teams. That's a great fantastic success that you're having.
All right, well, let's go into this a little bit because I think there's something really important here that we're touching on. Um, one is that I was thinking is as you were talking is HR probably does a lot of this kind of stuff of trying to come up with clever ways to connect. Maybe the marketing department sort of clever, out of the box creative. I wonder if there's any partnering that could go on there, any leveraging of those departments in what you're trying to do. So that's one idea I'd like you to touch on, this idea of partnering with some of these other departments. The other thing that I've heard is uh, it's okay to have a little fun and think outside the box, right? And that can be phenomenally effective. To Dirk's point of he tried something sort of very formal and it didn't work, and then he got a little fun. And oh, by the way, a lot of doctors probably into science fiction and this and that, and they loved that whole thing resonated with them, right? Oh, they got the reference to Star Wars and whatever. So think about your audience, Gretchen and your stickers. Like at some point, somebody found that funny, and they're like, "All right, I'll lighten up for a minute." So there's something important here. Let's go around the horn. Gretchen, you want to go first?
Yeah, I think partnering with our marketing and communications teams is key. They are vital to helping us get the word out. Another partner that we found is our chief medical officer, and making sure that we, utilize his platform whenever possible, and making sure that we can get the word out if something is changing, if there's something new coming, if we need their time. I'll circle back to the marketing. When we did those little fun Bitmojis back in the day, they started seeing them on the they didn't know they were in the clinical areas, but they started seeing them on our newsletter, and they said, "Oh, is that I don't think we should do that." And I was able to take the data to them and say, "We made a difference because of these, and
Mm,
here is how we moved the needle, and here's how we found success." So sometimes it's again telling the story and the why. Can we include these fun things? Can we maybe push the needle, push the line a little bit on some of these fun things to help with that engagement? Because it all goes back to meeting them where they are.
yeah, good stuff. Clara?
Yeah, I love the partnering strategy. I think if you ask our training director, she would say her dream is training is everywhere. It's embedded in every team, and that our IT training team and the HR learning group, because we have a team under HR that is also kind of focused on learning in general, are your subject matter experts to help you develop that curriculum. But ideally, training should be everywhere in every department. I think the partnership with Marcom really mostly is that spectrum of change management. So we have training and we also have communication in sort of helping us drive behavior changes, workflow changes, et cetera. But I think recently we've also started to partner with our IT help desk, which is fantastic. We moved our knowledge material, so all of our training documents now into ServiceNow, where our IT help desk operates out of. And so that now we all know people call help desk thinking something is wrong, but it's really more of a training issue. They're all accessing the same fund of knowledge now. And so that has been that is still ongoing, a big project for ours, but one investment that has been very worth our time.
Excellent. Dirk, anything you want to add?
Nothing to add, but actually, I'm kind of curious if Gretchen and Clara, if you can elaborate, just to trade notes briefly. Do you house all your training materials in one centralized place? And if so, where is that centralized place?
Dirk, you perfectly segued to the Ask a Co-Panelist segment, so well done. It's
All
like I
right,
paid you on
sorry.
the side. Go ahead.
We have it in, well, we currently are moving it out of where it was at into ServiceNow. So that way, like I said, our IT help desk can also access the same information. But then inside our EHR, we also have a learning home dashboard that links out to all of this. So that for the clinicians who live inside Epic, that's sort of their repository of all the training material. But it links out ultimately to wherever everything is at.
And we have a site called The Pit, so physician IT site, and it is linked within our EMR, so they can actually go out to a SharePoint site, and we do house a lot of our training in there. I wrote down the ServiceNow. I love that idea. We do have a run book basically that our service desk uses today on the Liberty side that goes through, and we try to provide some of that information whenever we have something new. We try to make sure that they have that information. But as we're rolling out ServiceNow, I think that's fantastic to have it at their fingertips. So I wrote that down and said, yes, please, let's do this. So I think, yeah, having it a location that they know to get it. I don't know how many we're really getting with clicks wise, looking at the data and, how many unique views and things that you're having there. It goes back to that push pull and how they want to get that. Some of them, even though it's right there and they could click that button, they still want to phone their friend and pick it up and say, hey, how do I do this? And have their physician support coordinator help them.
All right, very good. Let's go to you, Gretchen. Do you have a question for one or both of your co-panelists?
I have a question for Clara, for Dr. Lynn here. So you mentioned 9 months ago that you guys reorged and training and informatics came up under you. And prior to that, they were with the CIO. And you also mentioned that your class scores had steady improvement through 2024. So what drove that org change for you guys to move that up under you?
Yeah, the org change was more of a financial one. We had to do that in a financial reorganization of IT, and it made more sense for me to start to take on more within IT teams to sort of help with my boss's share of the work. But when we were designing what that looked like, it made sense that sort of training user engagement in general is aligned with informatics, and then the other group that I also inherited during that reorganization was patient engagement, which to us also is a user, sort of an end user. So we kind of put that all together and then under me. So I think that's what drove the change. But it really has been so helpful for the informaticists to be able to sort of help inform the strategy both in the digital health side and also in the training side.
Excellent. All right, Clara, do you have a question for one or both of your co-panelists?
Yeah, so I have a question for both of them, and maybe this is more of a general question. Speaking of sort of resources and struggles in sort of getting the resources, we really want to be at the elbow, as you heard, and try to be in your face as much as possible when it comes to training presence. But there are also times where required training we just can't get to everybody. And so now for some of our tools and applications, particularly for AI tools that are the use of them can be sometimes quite dicey. We're struggling between deciding whether a training needs to be synchronous or asynchronous. So can we record this as a webinar and send it out to everyone? So I'm curious if you have any sort of really off the bat at top of your head, like some criteria where you said this has to be a synchronous training, or we can try asynchronous in this situation.
Dirk, let's go to you first.
I mean, obviously, if your budget allows, synchronous is always great. My dad was a school teacher, and he always used to say that the best way to educate somebody is in front of them, because you understand your audience. You can anticipate what their needs are. You can, if they're struggling with a particular concept, you can help reinforce it. So having a one-on-one relationship is always, in my opinion, is more valuable. But obviously budgets are often short, and sometimes you don't have that. And so then you make recordings and you offer people the opportunity, but they can still walk away with gaps, or they can just not pay attention. So, it's usually better if you can, but I think we're all balancing that same resource struggle that you're talking about. Gretchen, do you have any thoughts?
Yeah, I'm a big fan of in person, but there are times that you have to do remote, or there's times that you have to do asynchronous training. I think where it comes down to is partnering with those operations teams to see what they need and then make that judgment on what can be something they could do on their own. Can this be a recorded webinar? I don't ever want that to be up to IT. I want us to make sure that we are partnering with the people who are going to end up using the tools to help guide us in how we put out that content for them.
It's a great point. Thank you so much.
All right, we have a minute or two here. Does any of you want to ask another question to the panel? Anybody have anything else that they'd love to hear some feedback on?
I'll ask the group. How do you guys, there's rapid change, right? We've got change coming at rapid pace, and this is something we're going to be going through rapid change. How do you keep up with the rapid change and keeping up with the content development? And I don't know, I just feel like there's so much on all of our plates right now. It's a balancing act. So how are you keeping up with the rapid change?
I have an answer. Clara, do you want to go first? So what I do is, and I'm happy to, if you want to geek out after this call, but I have very careful project folders for every single request, small, medium, large. And because of the rapid change, if I didn't organize my files really, really well, I would get lost, like, and so I'm happy to share, or Anthony, if whatever I can do to
Yeah,
support you and your
sure.
audience, but you really have to pay have really, really well organized project folders, but I'm happy to share with you.
So people would probably think you're insane if they saw your folders, right, Dirk?
It looks a lot like Wikipedia, basically. If you look, and everything is like, this discussion is related to this, and here's the hyperlink from
I
that, and
love it.
here's like,
Do you
so
use?
it's very well documented. I have all the
Yeah,
stakeholders, the executive sponsors, everything in one place. So that way, like when there's an emergency, I can jump to the folder. I know exactly who to talk to. I know exactly, here's the
that's
materials, here's
it.
the whole discussion.
That's it. I think that kind of stuff is very helpful. I don't, and maybe if you want to share what tools you use, you can, Gretchen, you can email with Dirk offline. But I find OneNote to be a very useful tool with hyperlinking around, so that's helpful to me. But where is your folder structure? What's that in? Is that just folders on
I
your
mean, I
computer
use
or online?
SharePoint. I use
SharePoint.
SharePoint because
Mm.
you can teach like pretty much anyone how to use, to develop in SharePoint in like 10 minutes. So once you have basic SharePoint skills, so my whole project team, we all have our same, we all use the same naming conventions, folder structure, file structure, so that way we can all jump back and forth and we know exactly like who had the last conversation, what did they do, what did they talk about. So you really have to organize your team, like, very methodically, but I'm happy to talk about it separately.
And yeah, I think you can lose things in SharePoint too, right? Right, if you don't label it the right way. I think, I don't know how much more time, but I think the question too is the change management and change overload for your end users and going through rapid change. I think that's something we could probably do a whole other hour on,
Oh yeah,
how we
yeah.
manage that and how we help them adapt and digest when they're going through these periods of rapid change.
Clara, any quick thoughts on that?
Yeah, I think to me that probably starts before the training part. That starts with the tool itself needs to be as unobstructive, unintrusive as part integrated into the workflow as possible, to then help with that change burden.
All right, very good. We're going to do a lightning round of final thoughts, and then I'm going to go let everyone go. So the way I usually frame this up is your best piece of advice to someone in your position at a comparable organization. So you across the country with 3 less years of experience. Gretchen, what's your best piece of advice to that person?
I think don't sit behind your desk. Get out there, talk to people, understand what their needs are, what problems they're having before you come up with solutions. Because what works for me may not work for you, right? We all have different budgets, we all have different team size, we all have different scope and responsibility. So I think we need to meet our people where they're at. I know I said that on repeat, right? But I'm a big fan of rounding. Don't just sit at your desk. Get out there, meet people, help to understand what they need so then you can provide them those tools.
Well, you like rounding and Clara likes infiltrating. So we'll go to Clara and then we'll see what Dirk likes. Go ahead, Clara.
Infiltration. I
Love
think
it. That's
like,
great.
that seems to be the word that I came up with today. But no, I'm going to take a page out of Gretchen's book and say that design your training approach around the users, and what the users need, and always work with an informaticist.
Mm-hmm. Yep. Excellent. Very good. All right, Dirk, you're going to get the last word.
I would just copy and paste what Clara and Gretchen just said. That's sound advice.
All right, wonderful. Well, this was a wonderful conversation. We covered a lot of ground. I think there's some great takeaways here, and we'll be doing some follow-up coverage on this, extracting some of the learnings out of this event for our audience. So you could look forward to that. Regarding continuing education, you can use the final slide in this deck. You'll get an email when the on-demand recording is ready for viewing. If you want to work with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for upcoming panels. And with that, I want to thank our tremendous panel, Gretchen Britt, Dr. Clara Lynn, and Dr. Dirk Stanley. And I want to thank you, our attendees, for joining us. And with that, everybody have a wonderful day. Thank you.